STArT was a phase 3 randomized controlled trial designed to be the definitive study, right? We utilized a network of multi-center institutions. So we used PECARN, which is the Pediatric Emergency Care Applied Research Network. And the beauty of the network is that it is made up of academic emergency departments where you've got physician scientists who have clinical trials experience. So couple the expertise in the emergency department with hematologists who have expertise in sickle cell disease, and that was the secret sauce to success. So STArT, actually, we randomized 271 subjects within 2.5 years, which is terrific. And we were nearly a year ahead of schedule for our enrollment, which is a success story in itself when you're talking about an orphan disease. So one of the challenges is finding the patients, right? So you need to go to centers that have a large population of patients with sickle cell disease. And then since we're enrolling in the emergency department, there's the chaos of the emergency department, right? Approaching patients and families when they're in distress and acute pain. But we have navigated processes to actually, minimize the impact of that so that we can successfully enroll studies in the emergency department. Our primary outcome measure was time to crisis resolution, and that was defined as the time that we started delivering the study drug, whether it was IV arginine or placebo, to the last IV morphine dose that the patient received. And with that, like I said, that time to crisis resolution correlates very strongly to their length of hospital stay. We also looked at other secondary outcomes, such as patient-reported outcomes, and that was interesting because what we found was that there was no difference in patient-reported outcomes, but patient-reported outcomes such as, pain and fatigue was actually worse at discharge than when they got there, even though their pain scores, so we ask patients on a scale of 0 to 10, where is their pain? Their pain scores were increasing by an average of 4, but their patient-reported outcomes that are supposed to reflect quality of life and pain were not improving. And I think one of the reasons is because patient-reported outcomes are designed to look back over the last 7 days. And if you ask a patient who was hospitalized for pain, how have you been feeling in the last 7 days? Well, they were in the hospital, they were in pain, they're being woken up at 4 o'clock in the morning for vital signs, right? So it is not necessarily an ideal outcome for acute pain studies, although it has a lot of benefit in other scenarios. So, at the end of the day, this study did not meet its primary outcome of time to crisis resolution. So on the surface, that qualifies as a failed study. But honestly, I really feel like we have so many lessons to be learned from STArT. We just published a paper by Chris Reese in American Journal of Hematology talking about the variations in outcomes and really trying to understand what are the challenges with time to crisis resolution. And in that exercise, we found so many variations and confounders that one can't control for in a clinical trial design. So things like, typically we know from past history that older children have longer length of hospital stay and a longer time to crisis resolution. So that's a truth, right? Younger kids go home sooner, older kids stay in the hospital longer. When we looked at, and this is just looking in the placebo arm because we wanted to eliminate any influence from arginine, when we looked at the ages, we lost that association of time to crisis resolution with age. And what we realized when we dug a little bit deeper is that it was more likely a reflection of the hospital that you got admitted to than how old you were. So institutionally, people have variations in practice, which, again, we knew this to some extent, but I don't think we understood how much this was impacting our clinical trials. And this may be a problem from moving from successful phase 2 trials to trials that are not meeting their endpoint in phase 3. So for an example, there was a mean and median difference of 118 hours and 80 hours between the two extremes of the hospitals, right? And we were looking for a statistically significant difference of 17 hours to say that our drug is actually doing something positive for patients. But if you just step back and look at the variations in the placebo arm, there were just so many confounders. that were much more impactful than even that 17 hours that we're looking for. We also identified other important confounders. So patients who had chronic pain, for instance, were admitted to the hospital longer, and their pain scores really didn't improve during their hospital stay, yet they got to a point where they could still go home. We had one site that gave sort of an IV dose of morphine for the road, sort of on the day of discharge. So that skewed our time to crisis resolution because these patients used very little opioids, but they had a longer time to crisis resolution because they got pain medications on day one, and then they were doing okay on the day of discharge. They gave them a dose as they were being discharged out. So all these factors that I actually was unaware of before I did this study. So again, we've learned a lot. I would change the way that we run our next clinical trial. I think one of the things that was exciting, though, was honing in on acute chest syndrome, because we published a phase 2 randomized control trial of arginine therapy that just recently published as well in American Journal Hematology, and we found a statistically significant difference in the arginine versus placebo among patients who had acute chest syndrome that favored arginine by a difference of 60 hours. Now, small sample size in a single center study. When we translate this to our phase 3 trial, again, we saw it wasn't significant, but it was a clinically relevant difference of over 60 hours between the two groups. And so that tells me, one, that maybe there's something unique about acute chest syndrome and arginine. We do know that all those patients with acute chest syndrome in my phase 2 trial had the lowest arginine levels of the group that came in. So maybe they are representative of a bigger arginine deficiency. But alternatively, patients with acute chest syndrome typically are admitted to the hospital for a week. So it may just be a reflection of the fact that they are in the hospital long enough for us to be able to make a difference. So I think stay tuned. I mean, I'm starting to recognize the fact that I may need to do an arginine acute chest syndrome study to answer this question. I'm really thinking that my next step would be to target specifically these patients with acute chest syndrome because they are a subgroup of patients who seem to do really well on arginine. And when we look at all patients who come into the emergency department, about 80% of them have an arginine deficiency. So based on our phase 2 trial data, that was also a study that did not meet its primary endpoint, which was total opioid use. But when we analyzed the data, just looking at patients who had an arginine deficiency, which is defined as a level below 60 micromoles per liter. So a normal level is between 60 and 100 in your blood. So if you have an arginine deficiency, those patients had a statistically significant difference in their total opioid use and a trend towards a decrease by 31 hours in their time to crisis resolution. So again, something happening within the arginine group that's deficient. And so I think the FDA calls arginine a drug because it's treating a disease, but we are treating a nutritional deficiency that's caused by hemolysis. And the challenge is that there are consequences of these nutritional deficiencies. And we've shown that arginine deficiency is associated with more severe pain. We've shown that it's associated with risk of pulmonary hypertension. Others have shown that it's associated with leg ulcers, and by supplementing with arginine, you're able to reverse the leg ulcer, size and shape. So I think that there's still more questions to be asked around arginine therapy. We have biological feasibility. We published a study last year looking at the pharmacokinetics of arginine, and we discovered that arginine combines with another amino acid, tyrosine, to form this it's an opioid-like dipeptide. So basically it's morphine-like without the side effects, called kyotorphin. And so by increasing kyotorphin levels, really arginine would be working as a pain medication. So we haven't really been thinking of it specifically as a pain medication. We've been thinking of it as an amino acid that is actually increasing nitric oxide production.